technology started with the three-dimensional reconstruction of coronary arteries using the 3D QCA, and then apply patient-specific coronary flow from TIMI frame count, and then applying the CFD or mathematical calculation, we can derive angio-based FFR. So QFR is one of the first modality of angio-derived FFR. The diagnostic accuracy of QFR from MEDIS medical imaging was tested in the FAVOR trial series. In FAVOR pilot trial, they compared three different QFR: the fixed QFR using fixed flow velocity, and the contrast QFR using TIMI frame count, adjusted patient-specific coronary flow velocity, and adenosine QFR is QFR measured under maximal hyperemia. As a result, contrast QFR showed best agreement with the invasive FFR, and this is now standard QFR. And later studies FAVOR to China also showed excellent accuracy of QFR, and FAVOR to Europe, Japan showed also very good agreement between QFR and invasive FFR, and more importantly, time to QFR was much shorter than the invasive FFR. And there is another platform. The CASWorks made FFR angio, which is more simpler than MEDIS QFR, also showed excellent accuracy. And the Chinese company RayMed, they also launched the CAE FFR, and this is also very convenient system using patient-specific aortic pressure in this console, and the overall accuracy is 96%. And the recent meta-analysis showed excellent accuracy of any angiographic FFR to predict invasive FFR. The overall sensitivity 90%, specificity 90%, and there was no difference across the different software or computational method. So Korean multicenter QFR registry evaluated 600 vessels. When we compare the diagnostic accuracy between the among the various clinical presentation, AMI non-culprit vessel, no difference with the stable patient, and there was no difference in the accuracy according to the previous myocardial infarction, diabetes, or target vessels, or region ranks. And more importantly, for the prognostic implication, patients with low QFR had 4 times higher risk of vessel-oriented composite outcome than the preserved contrast QFR, and the predictability for the future clinical event was same between QFR and invasive FFR. And in addition, the prognostic impact of post-PCI QFR was validated by Hawkeye study. From 750 vessels, the vessels with low post-PCI QFR less than 0.89 had a 3 times higher risk of target vessel failure than the vessels with higher QFR value. And one of the most interesting function would be the residual QFR function. This is the predicted post-PCI QFR after virtual PCI. In this initial study, 93 patients with non-STEMI was evaluated using residual QFR and actual post-PCI QFR and post-PCI FFR. As expected, post-PCI QFR good agreement with the post-PCI FFR, and residual QFR also showed good agreement with the actual post-PCI FFR. And Dr. Javier Escanet and the Korean group, we evaluated COE Perspective Korean registry, 600 patients who underwent post-PCI FFR measurement. When we analyzed residual QFR, its predictability for the actual post-PCI FFR was very good, AUC 0.856, and patients with low residual QFR less than 0.89 had a much higher risk of target vessel failure than the other groups. And the clinical usefulness of residual QFR is you can design your procedure before the PCI. So we can do the virtual PCI using this console, and we'll get the residual QFR, and based on that, you can decide your treatment plan. And there are 2 RCTs evaluating QFR's clinical impact. In last year, the superiority testing of QFR-guided PCI over angio-guided PCI, the China 3, Phase 3 China trial has been published, and the non-inferiority trial, which comparing the QFR versus FFR guidance, is currently ongoing as a Phase 3 Europe-Japan trial. So I think you may all saw this manuscript. The Phase 3 China trial evaluated 5,000 patients and randomly allocated those patients into the QFR group or angiography-only guided PCI group. So QFR guided group resulted in the about 20% less PCI, and at the 1 years of follow, QFR guided guidance resulted in much lower risk of MACE than the angio-guided group. Even after excluding the peri-procedural MI, those benefit of QFR-guided PCI was maintained. And we need to remember that regardless of what index we are using, physiology-guided PCI is not same with the physiologically optimized PCI. Those registry nicely demonstrated about 20% of patients still have low post-PCI FFR even after the angiography successful PCI. So what is that reason? Let me give you the same FFR value, 0.74, in these two different patients, however, totally different disease distribution. So the fundamental dilemma is FFR is vessel index. However, we are doing the region-specific treatment. This is the starting point of the discordance. So although many interventionists want one simple digit to decide your treatment strategy, however, patient disease is much more complex. So we can consider this type of two-dimensional mapping. So x-axis is physiologic distribution, focal versus diffuse. Y-axis is local severity. So how should we measure the physiologic distribution? The recently PPG index was suggested. This was from motorized FFR pullback, and PPG index integrate delta FFR in 20 millimeter over entire vessel's delta FFR and functional length of the disease. So PPG close to 1 means focal disease. PPG close to 0 means diffuse disease. This is very complicated procedure. We simply cannot do that in my cath lab. However, if you are using QFR technology, this will be very, very, very easily done. And how can we measure local severity? So our group suggested the concept of local QFR or FFR gradient. We can simply transform this pullback curve into the reverse one. So in the previous manuscript, if there is major FFR gradient, the PCI will result in the sufficient FFR increase after PCI. If there is no major FFR gradient, the PCI will result in the suboptimal relative FFR increase. Again, QFR technology can easily realize this concept. So let me show you some case examples. These are for the physiologic distribution. When we analyze QFR PPG index, the left one is focal disease, right one, diffuse disease. Those two patients had the same QFR value. For the major gradient issue, the left one, major gradient on the QFR gradient, based on the QFR gradient analysis, the right one, no major QFR gradients. So we can consider this kind of two-dimensional mapping. X-axis is QFR PPG, Y-axis is local QFR gradient. So when we analyze post-PCI physiologic result, in patient with diffuse disease, there was higher proportion of low post-PCI FFR. In patient with no major gradient, those patients resulted in the suboptimal increase after PCI. When we see the clinical outcomes, after successful local treatment, the patient outcome will be determined by physiologic diffuse disease. So we can consider this type of approach. As Dr. Johnson mentioned at the beginning of this case, the predominantly focal disease with major pressure gradient, this would be the best candidate of PCI. However, in patients with diffuse predominant diffuse disease without major gradient, bypass surgery should be considered. In patients with focal disease, however, there is no major gradient, we can do the medical treatment alone and sometimes consider PCI. The problem is group 3. On top of diffuse disease, if there is major gradient, PCI can have some role. However, intensive medical treatment is much more important in this patient. So these previous concepts are still under testing, and the most recent version of MEDIS QFR already integrated QFR PPG and QFR gradient. Having said that, in my daily routine practice, this patient with dextrocardia and RCA STEMI, after treating those RCA, I wanted to measure the physiologic index in the non-culprit vessel LAD and diagonal branch. And as this patient was dextrocardia, engaging the guiding catheter was not easy. So I simply do the contrast QFR, and based on insignificant value, default those non-culprit vessels. And another interesting use in daily practice is reviewing the past angiogram. This patient presented with the LAD CTO, and we have the past angiogram which was taken 60 years ago. So when we analyze those past angio, the QFR was already very, very low since that time. So if I treat this patient 60 years ago, that patient probably okay at the current time. So this is my last slide. Angio-derived FFR is feasible and reliable, and you can use any platform which is available in your country. And angio-derived FFR can provide planning based on the residual QFR or two-dimensional mapping. And phase 3 China already showed superiority of QFR-guided PCI than angio-only guided PCI. Thank you for your attention.